their mouth open. Gary is going to take it from here and we'll get started with our speaker.
Okay, so as always, we're asking everybody to stay on mute and put your questions in the chat, and we can feed them to our speakers as they come in. And otherwise, it's over to you, gentlemen.
Okay, great. Good morning, everyone. I'm Tom Wilson. I'm the Executive Director of the Northern Virginia Dental Clinic. And first, I'd like to thank you for inviting myself and Dr. Wagman to join your group today and talk about oral health and the importance of it. The Northern Virginia Dental Clinic was established in 1994 by members of the Northern Virginia Dental Clinic. So we're in Northern Virginia Dental Society, excuse me. It's a professional group of about 1,400 doctors throughout Northern Virginia. And they felt that there was a need back then because there was no other resource for low-income and elderly residents to access oral health care. So we've been in business now for 28 years. We are a 501c3 nonprofit organization. The majority of our providers are professional volunteers who come into our facilities. We've got two facilities, one in Fairfax, very near the Fairfax Nova Hospital over on Gallows Road, and the other one is out in Sterling, Virginia. So as far as services go, we provide comprehensive examinations with intraoral and extraoral radiographs, oral cancer screenings, as part of the examinations to determine what your needs may be. We then come up with a detailed treatment plan and make recommendations for treatment that you may need. We do restorative procedures, which is fillings. We offer oral surgery, all types of oral surgeries from pretty straightforward extractions to very complex extractions and some other procedures. We do hard and soft tissue biopsies if needed. We do endodontics, which is root canal therapy. We do prosthodontics, which is the fabrication of dentures, partials, crowns, things like that. Of course, we do cleanings. And of course, one of the most important things that we do is patient education, because we want everyone to maintain a good state of oral health so that it doesn't compromise your overall health. So those are the services that we provide. We do, there is a process to get to our program. For Arlington County residents, it's through the Arlington County Department of Human Services. We have a point of contact there, and I'll provide that to Gary at the end of the presentation, the individual's name and telephone number in case you want to contact her to see if you're eligible to come to our facility. Eligibility includes that you are a resident of Arlington County, that you are age 18 or older, and that your income eligibility. Now, income eligibility for our program is at or below 200% of poverty, which is pretty generous. But I can tell you that probably about 97% of our clientele is at or below 125% of poverty. So we truly are providing care and services to those of very low income for various reasons. We do probably about 10 to 15% of our clientele is seniors. We do fabricate, as I mentioned, dentures, partial dentures for missing dentition, which is important so that you can properly eat and bring nutrition to your bodies. And so those are the type of things that we have. Now, just to mention, there are two other resources that I'd like to mention since we're talking about Arlington County. The Arlington County Department of Health does have a dental clinic over in their building off of Washington Boulevard. and it does serve residents that are age 60 or older, but it's really basic services, examinations, fillings, and even extractions are done on a case-by-case basis. Now, many years ago, I've been with the dental clinic for about 25 years now. Early on, maybe 15 plus years ago, they used to do dentures for seniors, but they no longer do that. So we are one of the only programs in the area that does as comprehensive of a menu of services that the NVDC does provide. There's also another resource which is called Neighborhood Health. It's a federally qualified health center. They've got multiple locations throughout Alexandria. There's one in Arlandria, and then throughout Fairfax. But once again, their menu of services that they offer is not as comprehensive as ours. So that's basically about it. As I said, at the end of the presentation, I'll provide some information to Gary, along with the information I mentioned about our contact with the Department of Health, Arlington County Department of Health. I will provide our address and our contact information directly, and you're welcome to give us a call, and our administrative staff can guide you on how to get qualified to come and be a part of our program. And we certainly look forward to providing you some good oral health care if you become a patient of record of our program. And with that, I'll turn it over to Dr. Jeff Wagman, and he will discuss some things to do to ensure that your oral health maintains at a high level. Thank you.
Thanks, Tom. Hey, everybody, I'm Jeff Wagman. I've been been volunteering and been on the board of the dental clinic since probably 1995. I graduated school, dental school in 95, and I grew up in Northern Virginia. I was born in Alexandria Hospital, went to Jefferson, went to college in Virginia, went to dental school in Virginia, and came back here. And took over the work of my father's practice, and eventually took it over. My father graduated from NYU in 1958. He came down here and took over from a fellow named John Ashton, who was the first formally educated dentist in the city of Alexandria. So our practice goes back to about 1910. And I am happy to say that I'm still a dinosaur. I still practice like the old way. A very small practice. We see one patient at a time, and most of our patients are geriatric. It's not because we're special or we advertise it, it's just the way things have evolved. And oral health care needs have changed dramatically from my grandparents' generation to my parents. My father's deceased, but he would have been close to 90, and my mom's 82. So that would be a lot of the peers for you guys, or even younger. You guys are even younger, to my generation and my kids' generation. And but it still always comes down to the basic problem of access. Is it economic access? Is it transportation? Is logistic access? Is it education? A lot of people I see can't fathom losing a tooth. They don't want to be like their parents or their grandparents. They remember as kids seeing their grandparents' teeth in a glass jar, and they don't want to be like that, and so they want to save teeth. Unfortunately, dentistry is terribly expensive. It's terribly expensive everywhere, but this area is, we're up there with New York City and Miami and Chicago and Los Angeles as far as the cost of healthcare. And it simply isn't feasible for a lot of people. So patients often have to make difficult decisions based on economics. I would guess with my generation, we were the first ones where we didn't have the problem of cavities. And we also wholesale went to dentists regularly as children. My dad, when he graduated dental school, had 16 crowns already. Now, he didn't have fluoride growing up, and he liked hard candy. And he still liked hard candy to the day he died. but it's, without the access to fluoride, he had a mouthful of fillings. He also started with dentistry before there was wide use of local anesthetics. And so, contrary to popular belief, not all dentists are sadists. Most dentists care about their patients and don't want to hurt them. And so what we found over time is a lot of the fillings that were done without anesthesia all the decay wasn't taken out because the tooth was beginning to hurt. And so the fillings failed, and then, they got infected, and patients couldn't afford or didn't have access to root canal, so they just lost the tooth. And you can imagine, as you lose teeth, you then put more force and more load on the existing teeth you have, and you can see the domino effect. So what we really try with education is educating people to save the teeth they have. I'm going to sidestep real quickly to something that Anita said early on about having somebody come with you. Multiple problems I have when looking at a new patient that is 65 and older is hearing, listening, and understanding. I always try, if they bring a family member or a friend and they agree to it, of course, I don't want to violate HIPAA. I always encourage somebody to come in the room with them so I can explain it once and ask questions. Because oftentimes the person in the chair is already afraid. Fear is something that we work with all the time. Fear of the unknown, fear of pain, fear of the cost. So it's helpful to have an objective set of ears that, to listen and to ask questions. The Northern Virginia Dental Clinic has been a true blessing. At its time and its founding, it was the first in the country. It's a private-public partnership between the local counties and our patients. And the other thing that's unique about the Northern Virginia Dental Clinic is we offer comprehensive care. It's not emergency based. So when you come to you, we're going to restore you to optimal health. What I have found in Northern Virginia is we have a lot of retirees that make too much money to qualify for clinic, but not enough to afford private care. And this is a conundrum that we're struggling with. And how do you help a lot of our patients? And it's difficult. It's difficult to have to make a decision where medically we can save a tooth, but financially the patient can't. And I think every dentist out here will try and do what they can to help somebody, but we are running businesses and we have other patients. So what do we do? And I think one of the problems is a lack of safety net access. There's lots of clinics and lots of safety net organizations for children, but not for adults. You can't get a job without your front teeth. You're not going to live a healthy life if you can't properly chew your food. And so it's an ongoing struggle that seems to be becoming more and more acute. COVID has really exasperated the need in Northern Virginia. For a while, patients couldn't come to the dentist, so they put off dental care for a year, 2 years. And then, I think the fear of the unknown has kept people away also, because they just, have catastrophized in their mind what is going on in their mouth. And it's rarely as bad as you think it is. And I think I'm getting sidetracked here. So I'll quickly touch on a couple important things. There is no dental care with Medicare. So contrary to popular belief and what you see Joe Namath saying on TV, Medicare does not have a dental component. Medicare Advantage that they advertise on TV is not Medicare. It is licensed through the CMC to use the Medicare name, but it is third party. One of the problems that happens when you retire or lose your job is you lose access to your health care. Rarely is there a Cobra plan for dental care, and if it is, it's terribly expensive. What a lot of patients don't understand is your company, whether it's the federal government, which is, we have a lot of military and federal government retirees here, or private industry, picked up the lion's share of the dental premium. So once you retire, you have to pay for 100% yourself. which, is cost prohibitive. Then on top of that, what they advertise is usually just preventive service, which is 1 or 2 checkups a year. Rarely pays much on crowns or root canals or implants or dentures. It'll pay more on emergency service like an extraction or perhaps a basic root canal. So we have created a system in this country where once you're done working, you're out on your own. And it's a shame because the older population in this area wants to keep their teeth. And they have to make hard decisions what to do. And, from a dental professional standpoint, it's hard to try and tell patients that don't buy this insurance plan because you're throwing your money away, because they've always had insurance and they think that it'll cover the same. It doesn't. I saw somebody in the chat room say something about dental insurance sucks, and it really does. It's gotten steadily worse every year. So on the big scale, if we need to come up with something that will help people, a universal plan to help people with dental coverage. So let me just quickly look at the chat here. I saw a couple of questions here.
Dr. Tom, we can keep an eye on that. You can just make sure you cover your basic information, and Gary and I will let you know.
Okay.
Yeah, there is a question that came up early on about what's the most economical service for people who are missing a lot of teeth. And we can ask the questioner to expand on that if it's not clear what they're really asking.
Well, okay, so that's a tricky question because a lot of times patients hear about implants and implant supported dentures and they don't understand the cost. And everything associated with implants is not covered by most insurances, so it's out-of-pocket expense. Very few private practitioners in this area do a lot of dentures anymore, so it falls on like the Northern Virginia Dental Clinic, the safety net clinics that do dentures. It's not that it isn't taught, it's just not. I mean, a lot of people around here still have their teeth or have some level of, some number of teeth to do it. So it's tricky. What do you do if you're missing a lot of teeth? And the answer is, if you fall in that category of you make too much money to go to a safety net clinic, but not enough to afford dentures, it's difficult. And I don't have a good answer for you. You?
Well, if I could interject here, there are a couple programs. There's a business known as Affordable Dentures. Now they do fabricate different levels of dentures as far as quality, and obviously as they deem it a higher quality denture, the cost is going to be more. Now I can tell you, and I failed to mention this earlier, at the Northern Virginia Dental Clinic, what we do is there is a fee associated with your visits to the clinic. It's $50 per visit. Now, for that $50, what that $50 buys you is not a specific procedure. It buys you a block of time, normally 45 minutes to 1 hour in duration, in the chair with a healthcare professional, either a dentist or a dental hygienist. And all of our volunteers and paid staff professionals understand that they are to provide as much care as they reasonably can accomplish within the allotted time, the 45 minutes to an hour. So if you, let's say that you have one tooth that has 4 or 5 surfaces that need to be repaired, restored, that may be what you get for your visit that particular day. But there may be another day that you come in and have 2 or 3 teeth in one area of your mouth, and the doctor can get all those done. So that's what you would get. You may come in and see an oral surgeon and have a number of teeth extracted. It's still $50. The only differences or beyond that is that for root canals, we do charge $100. But even to have a root canal done at $100 versus what private practitioners most private practitioners charge, let alone an endodontist, it's a huge difference. Board certified endodontists are currently charging somewhere on average between $1,800 and $2,000 for that same root canal. And it would be $100. And if the case is to a point of difficulty that we feel that it would be better for you to be served in the outside than at our clinic, or we can't do it in the clinic, we have set up a network with a number of endodontists throughout Northern Virginia that will take you into their private practice on our behalf, do the root canal, and then send you back for the restorative portion. So you're still getting that root canal done by a board certified endodontist for $100. So that's an incredible thing. Talking about the prosthetics and going back to what I said earlier about the business known as affordable dentures, we fabricate full dentures, the conventional acrylic denture, and then we also fabricate 3 separate kinds of partial dentures. One is full acrylic, one is with the cast metal framework, and one is with a more flexible acrylic called Valplast. So we offer 3 different types. Now the dentures itself, for a full set of dentures, complete upper and lower, it's $800. And that is for the appliances, upper and lower appliances, and all appointments associated with the fabrication process, and then up to 45 days for adjustments that you can make up appointments. So that's what we do with our dentures. Our partials, it's a little bit harder to narrow down an exact price because it depends on the type of partial we're going to fabricate for you and the number of teeth that are being replaced. But when you're in, and if you need a partial, that would be discussed with you by one of our healthcare professionals, and they may lead you in one direction, what they think is in your best interest. But of course, if we say that, we recommend one with a cast metal framework because that's going to last you the longest, and that's too expensive for you, then we can look at the other options, which might be a little bit less expensive. So
one of the questions, and you just asked, made me chuckle. From access, the next biggest complication we have as we age, not only just wear and tear. I mean, nothing lasts forever. Your tires in your car don't last forever. And a lot of you that don't drive a lot realize you have to replace your tires every few years, even if you don't use them, because they dry rot. Well, teeth wear out. And one of the major battles that I fight every day is every systemic illness has an oral manifestation, which means that your diabetes, your blood pressure, and the medicines associated with that have an oral side effect. I don't know if anybody in this room is on metformin or anybody in this room is on certain blood pressure medicines, and they wake up every morning with a bone dry mouth. And so one of the things we find is recurrent cavities around old fillings and crowns because of the struggles. You need to take the medication to survive, but it's, you're losing the saliva, which not only buffers your mouth and keeps it at a neutral acidity, it also lubricates the mouth. And so that, things work better. Also, end of age, Parkinson's, dementia, some of the other things, you just physically can't maintain the oral health care. And it is, for me, sad when I see somebody that struggled their whole life to maintain their teeth, and then the last few years things start to fall apart. There are certain things we can do that help. Like I will prescribe fluoride or make trays for patients to wear prescription fluoride every night to help offset the recurrent decay. I obviously can't tell them to stop taking their blood pressure medicine because that's counterproductive. The other thing that's changed a lot since the 60s is we don't see as much periodontal disease today as we used to see. And part of that is education. You've been told since you were young to brush and floss your teeth. There is a direct link between periodontal disease, gum disease, and heart disease. There is not a reverse link between heart disease and gum disease. So it has something to do with the bacteria that's involved in gum disease. So yes, Anita, flossing will make you live longer. But there are other tools, electric toothbrushes, water picks, proxy brushes. We have a lot more available methods to maintain our teeth. So part of it is, like I said, it goes back to access, being able to come regularly, fix things when they're small, not wait for them to become big. If you do have a bad tooth, getting it out before it spoils the rest of your mouth. But so awareness and access are probably the two biggest things. Costs, and then other medicines, kind of fall behind there. I feel like I'm missing some stuff. So, Gary, if you want to pose some questions.
Yeah, there's one here. When we were talking about Medicare, are you aware of any legislation trying to change Medicare so that it does cover dental?
Yeah, that petered out 2 years ago, I think it was, right? Or at the beginning was Biden's administration. Because one of the reasons, and the ADA fought that, it made us look bad, American Dental Association, but they had completely unrealistic cost structures and treatment structures. They were offering, I think it was $35 per extraction. They were offering to pay $500 per denture. Well, most of us that won't even cover our lab costs to make the denture. And so it died its own death in Congress. I think most dentists that support organized dentistry agree that we need to do something. But the problem is what the cost structure isn't going to, if it's not going to cover the cost just to fabricate things, let alone the time and the appointments, it's a non-starter. And that's what we ran into with the legislation that on this last go around. And I'm not sure it's dead. I think it just didn't go anywhere. It's pigeonholed.
I think they still may be having discussions surrounding that, but it's not progressing forward at this point.
I mean, the lab costs to fabricate a denture, and I'm going to jump ahead to another question here about what are they made of, has stabilized over the last few years, and it really costs the same to make a basic denture here in Northern Virginia as it does in Appalachia, North Carolina. Material costs and time are the same. Now, some labs are more expensive and they offer a higher level of care, and not everybody needs to drive a Mercedes. A Chevy is fine for a lot of people. And, the standard of care in the United States, Canada, and Israel, which have the highest standard of cares, our basic dentures are better than most dentures in the rest of the world. As far as what it's made of, most of them are made of acrylic. The teeth that are set into the acrylic denture are made of a heat process, they're a little stronger. We don't make porcelain teeth on dentures anymore, mostly because they chip and they click. I don't know if anybody had grandparents or their teeth clicked when they ate. We've tried to go away from that. One of the neat things that we can do now is we can actually 3D print a set of dentures. So in the labs I work with, you take digital scans, or you can still do the old-fashioned impressions, and then they scan them at the lab and load them onto the computer, and then the printer makes them. The advantage of that is there's less lab time, less processing time, and if the patient cracks their denture or loses their denture, or one of the biggest things that we find is they go to the hospital for a procedure and their teeth are lost at the hospital, we have that digital record so we can fabricate a new one at minimal cost. So technology has helped a lot. It's still in its infancy. But now, as far as partial dentures, in my office, if somebody needs a partial, I'm going to try and convince them to do a cast metal partial. Think of your glasses that you wear. If you wore resin or plastic frames, are going to be bigger and bulkier than if you wear like a very thin pair of titanium frame glasses. So the metal can be smaller, it's stronger, and much more. Once going back to digital dentistry, it's all digitally designed and it fits much better. The better fitting the prosthesis, the less wear on the remaining teeth. The better fitting the complete denture, the less wear on the gums and the remaining bones, so the dentures last longer. So what we're making now is of higher quality and better fit, so there's less likelihood that you're going to have to replace it every 5 years or 10 years. You know, a good partial denture will last you 20 years. And most of the time when the patient needs a new one is because they've lost some more teeth, you know, or they dropped it, which happens.
So I happened to see two other questions popped up. One about the state providing funding for dental care. July of 2021, the state Medicare started a adult dental benefit. Prior to that, the only thing that was eligible for adults was an extraction on an emergency basis. They'd pay for the extraction and they'd pay for one x-ray. Now there is a more comprehensive service out there for Medicaid, the state Medicaid program. But there is still some holes in that. So for instance, you can now get a root canal done through the Medicaid. But if you had a root canal that failed and it has to be retreated, they will not cover that. And so there's still some holes in it. It's not totally comprehensive.
Well, also, if I interject, if as of the early go around, if you had the root canal done, Medicaid wouldn't pay for the crown on the tooth.
Right.
So then a lot of times what will happen is if you don't put the crown on the root canal tooth, it begins to break down, they lose the tooth anyhow. So it's the other problem with the adult Medicaid, even though they recently increased the reimbursement by 30%, it's still roughly at about 50% usual and customary fees for this area. And one of the reluctance is not so much that dentists, you know, won't be willing to treat a certain amount of Medicaid patients, but when it takes between 90 and 180 days to get reimbursed from the state, it's simply unrealistic business wise. And so that's one of the struggles that we have convincing practitioners to accept Medicaid. Now, I know some of the dental schools are beginning to teach this, encourage the recent graduates to participate, you know, so essentially start at the ground floor rather than convince dentists that were practicing 30 to 40 years to go ahead and go back and try and accept Medicaid. So Virginia has a decent program now. I won't say it's good, but it's better than it's ever been. And this does help fill in some of the gaps because the requirements for Medicaid aren't as stringent as the requirements for the dental clinic, right?
Right, that's
Yeah.
correct. Another question that I saw pop up was someone had wrote a question about when's it time to sort of cut your loss and get all your teeth extracted and go to dentures. Now, I'm not a dentist, but I've been around dentistry for 40 some years now. And I'll let Jeff really attest to this at a different level. But if you decide to do that, anytime you have your natural dentition removed, you have to remember that you're going to start getting a lot of bone loss. If you remember back when we were looking at pictures of our grandparents or even a picture of someone older than that, you often saw where their mouth looks like it's shrunken in because of bone loss. And as that bone shrinks and your mouth begins to collapse more and more, it's more and more difficult to replace it with something that's going to be really functional for you. So with having said that, I'll let Jeff address it to a greater level.
Yeah, so one of the common misconception is bone doesn't hold teeth. Teeth hold bone. So if you pull a tooth out, you lose the bone. Think about if you pull your fence post out of the ground, if you don't replace it right away, the ground collapses into a hole and you've lost. And once you lose bone, you can't put it back. And so one of the interesting things about just touching on dentures is we can make a beautiful upper denture that fits well. The number one complaint about the upper denture is it covers the roof of your mouth. You can't taste their food. Their speech is changed. The lower denture, we will try our best to save some teeth because the problem with the lower denture is the tongue and also loss of bone. So they just float there. The other thing is when you lose a tooth, what holds the tooth into the bone is called the periodontal ligament. In that ligament, there's a bunch of innervations that specialized nerves that not only help us learn to chew, You know, if you bite into a nut, you chew with a different force than you bite into a spoonful of rice. And that's a learned behavior. But also the nerves, when you start chewing, when you stimulate the tooth and you stimulate those nerves in the periodontal ligament, it turns on your digestive tract. So once you lose the tooth, you lose that access. So people chewing with a denture don't process their food as well as somebody that has their natural dentition. Now, as an aside, we have that same problem with implants. You know, the only thing that implants will do is allow you to bite with more force and also restore the teeth to look like teeth. But you still have to, it's like, you know, if you lost your right leg below the knee, you're not going to be able to walk as well as you could before. Now, yes, you can walk, and you have to learn to walk again. So whenever we put a prosthetic device in somebody's mouth, they have to learn to eat again. They have to learn to speak again. And it's never quite the same. So a lot of what we do is try and educate people long before they're at the point where they have to pull the plug and lose their teeth. You know, so the kind of the sarcastic answer is the day before never do you cut your losses if we can. But that's not, you know, sometimes we have to make that decision. It's financial, it's access. Once again, back to access. They just can't afford to go to the dentist time-wise, money-wise, to save their teeth they have. And they just need to, like, you know, what can I do that would be the simplest, most straightforward, and most acceptable solution? And that sometimes is still dentures.
Any other questions, Gary?
Yeah, there's a question here about x-rays and how frequently do people need comprehensive x-rays? The writer says they don't like having them more than once every 2 years or so. And I wanted to expand on that and ask, has the nature of dental x-rays changed over time so that your exposure to radiation is less than what it used to be?
Well, once again, I'll let the doctor talk in more detail to that, but technology has changed. Used to be that you got high doses of radiation or higher levels of radiation when they did like a Panorex many years ago, you know, 20, 25, 30 years ago. The technology of today's machinery, devices, X-ray devices, the exposure rate is much less, but it's cumulative. Once your body takes that radiation in, you know, the next time you get it, it's just cumulative. Now, I do know that for extraoral radiographs, panoramic X-rays, they're called, those, the recommendation is once every 3 years. For intraoral radiographs, if you're having a comprehensive evaluation done and they're doing a full mouth series, that I'll let Jeff address. But I do know that in our facility, we only take x-rays that are absolutely necessary. We're not taking them just to take them, because we do want to minimize the dosage of radiation and exposure that individuals are getting. Jeff?
So the dental clinic uses the same system I use. And I think quite a few, I would say greater than half of the dentists in Northern Virginia use digital radiography. So, you know, instead of having a piece of film, which is exposed and then developed, we use a sensor. The systems that we use, they're 97% less radiation than traditional film. It's, instead of having, when you're exposed to an X-ray, it used to be an old wavelength, that it was a constant beam. Now what it does is it energizes the head and sends out a single pulse. So there's very little scatter. So you're only really X-raying the teeth that you're looking at. I am very conservative. Part of it is because of the digital X-rays are instant. I remember when I first came to practice and we had film, my dad would take, you know, 21 X-rays to get a full mouth because he didn't know, you had to overlap them in case you missed. Now I may take 7 or 8, even with the reduced radiation, because I can see what I need and I don't need to take extra X-rays. Our extraoral, so anybody that stood by the machine and went around your head, it's called a Cbct. It's cone beam computerized tomography. So it uses a scanning imaging, similar to anybody that's been through TSA lines at the airport and have to stand in the machine where you put your arms over your head. So it's not a traditional X-ray anymore. And at the dental clinic, we actually can do a 3D model of your jaw, which is really helpful for biopsies. It's really helpful for root canal to see if there's, because you know, in a two-dimensional piece of film, you can't see a crack in a tooth, whereas in 3D we can. So our diagnosis is much better. But if you look at the insurance standards, most insurances will pay for bite wings, which where you bite on the tab, it shows the bite top and bottom once every year, and a full mouth, either individual x-rays or a panoramic scan at once every 5 years. I'm very conservative. I probably don't do the scans, especially somebody that's in stable condition. You know, I'm just maintaining their oral hygiene, more than 2 years for bite wings and 10 years for panoramics. I have patients, once again, diabetics, especially difficult, that I have to take x-rays more often because they're having constant problems. And so it's risk of management is what it comes down to. I don't know if that answered the question.
Okay, there's a question here. Are there any dentists or organizations that visit assisted living or memory care facilities where the patients can't travel to the office?
I know that there's a dentist that has a mobile van that goes to the Goodwin House, Bailey's, Goodwin House, Alexandria, and I think the Fountains of Washington House. Actually, when I was younger, I used to go over to the Washington House. They had it was actually a podiatry chair, but you know, they had an x-ray, had some basic dental stuff. And I would go one Friday afternoon a month to try and see patients there. But I think it's case by case.
Yes,
Yeah.
it is.
Tom may
Yeah.
know more than this I do.
There's not many dental mobile units that do travel, and there's also some there's maybe a handful of doctors that I know of in Northern Virginia that has it's basically a pull-along suitcase that has the capability of has a small generator in it and suction device and stuff like that. But there's not much power there, and so their work that they can do is limited. But the problem with the mobile units is that they are costly to set up, and then you have challenges with black water and things like that as far as disposal of waste. So there's not many in Northern Virginia. I only know of 1 or 2 mobile units, and so that's about it. But nothing that goes and visits senior living facilities or anything else like that on a regular basis.
And the particular person I know that does this, I mean, his fees are astronomical. You know, you would think that, you know, he's got lower overhead and he's bringing his services to people that it would be cheaper, but no, he charges a lot of money. So yeah, what happens is I have patients that come in wheelchairs. My building's older. I don't have an elevator to the 2nd floor. I have a chair lift. But I think what happens is basically if somebody can't get if they're in a wheelchair or they're not mobile at all, they unfortunately just deteriorate. It's still pretty medieval, unfortunately.
Now, you talked about teeth wearing out over time. So the question was, is it expected that people are going to lose teeth as they age? And they wanted to know, you know, what are the things we can do to preserve them? And you've talked about electric toothbrushes and water picks and flossing. Do you have recommendations for specific brands or types of toothbrushes or water picks?
The answer to your first part of the question is actually today people expect to keep their teeth. So that in one generation we flipped. So the World War II generation that, you know, came back, they fought to keep their teeth. Their kids expect to keep their teeth. So that has changed, at least around here. I mean, we live in a very educated area and people will do what is necessary to stay healthy. So yeah, I mean, I think pretty much everybody in this room here, whether you've lost a tooth or two, wants to keep their teeth and expects if they can to keep their teeth. So what do you do? It's as far as brand goes, 10 years ago, this was a simple question to answer because it was the Philips Sonicare and the Oral-B. But now there's a bunch of other ones. I usually tell people if they sell it at Target, it's probably fine. If you buy it on Amazon, be careful, because and if it sounds too good to be true, it probably is. I mean, it's one of those things where, it's $30 and it says it does the same thing that the $100 Sonicare does. And it might for a week or two, but then it'll break. But as far as water picks go, I'm not really sure. I mean, one of the biggest complaints I have with water picks is real estate. They take up too much room. So if you're living in assisted living or even in a smaller apartment, you just don't have surface area to put some. You remember the old Teledyne water pick from the 70s? They have smaller ones. But as we lose our dexterity, arthritis or just neuropathy and other things, flossing no longer becomes viable for a lot of patients. They just can't do it. So I actually use these they're like little swords, so little picks. I like them and I give them to my patients. Maybe I'll put this in the chat what the name of it is. But the biggest thing is brushing your teeth for 2 minutes. There's a reason why there's a 2-minute timer on electric toothbrushes. The average person with a manual brush brushes for 26 seconds. That's not going to get it done. And so if you can spend at least once a day in the evening, preferably, because you have the whole day's worth of your chewing, to really, if you can't floss, then use, proxy brushes or little picks and electric toothbrush in the evening. That's the best thing. Tom's always saying that.
Soft bristle,
Oh, right.
circular motion.
Yeah. So the other thing is, a lot of you guys grew up with hard toothbrushes, and were told to brush as hard as you can. And that is not the current philosophy. You want to use a soft bristle with a kind of a lighter circular motion. Think about when you're trying to clean the tile in your bathroom. The grout's got some stain on it, maybe some mildew. You can sit there and press as hard as you want, and it's not going to come off any quicker than if you use a light circular motion and really agitate the bristles. So you want to back off. You don't want to saw. You want to use, if you can't circle, just do like a light vibrating motion, because the heavier brushing can also cause erosions and cut away at your gums. So anybody that has some receding gum lines, not only do you have that, then you have sensitive teeth because the root's exposed and stuff like that. And also the exposed root is much more prone to cavities if you have a dry mouth. So you definitely, a lighter, more thorough brushing is optimal.
Okay, question here. Can we get your website?
Yes, I'll give that information to you, Gary, and then you can post it. For
Yeah.
everyone.
Along with our Arlington County contact.
Right.
Yeah.
Well, very good. This is, we're wrapping up here, and I want to thank Dr. Tom and Jeff for introducing us really to the Northern Virginia Dental Clinic. This is a great resource for everybody in Northern Virginia and around the region. We'll look for your follow-up information, and thanks to Carolyn for setting this one up. Here's Dr. Jeff, you were saying it's called Opal, like the gem, Opal Pix, P-I-X, by Ultradent. And what is that device?
These are just they're little toothpicks. They're little swords that fit. They're very narrow in their texture, and they have a nice little handle. One of the worst things you guys can do is take one of those little round toothpicks from a restaurant, because you're sticking a round object in a triangular space, and they're made of balsa wood. So they're actually, but most of the time, a lot of people go to CVS, they have like Butler or Gum products have the little white plastic picks with a little fuzzy brush on the other side. So whatever you can stick between your teeth to get the food out, stimulate the gums works. Flossing's still the best. I don't know a single person that enjoys flossing. So they do it because they're told to do it, and a lot of people don't do it well. So whatever tool you can use to help is optimal. I hope that Tom and I, gave you some information. And if there's some follow-up questions, I think Gary and Tom will, we can try and answer them the best we can.
Very good. Well, thank you. It's Dr. Jeff Wagman and
Yes, correct.
Tom Wilson, who is the executive director of the Northern Virginia Dental Clinic. Thank you, everybody, for joining us today. We'll see you next week. And meanwhile, have a good, stay cool week.
Thank you.
Thank you. Yeah.